Microscopic examination of urine. Microscopic examination of urine helps to analyze the cellular and non-cellular elements that are insoluble and have accumulated in the urine following glomerular filtration and during the passage of fluid through the tubules and the lower urinary tract. It also serves as a confirmatory test in case of erythrocytes, leukocytes, and bacteria, which are also detected by multiple reagent strip method. Principle: insoluble cellular and non-cellular elements in urine are detected by direct visualization under the microscope. Sample: around 15 ml of freshly voided, clean catch midstream urine should be collected in a clean dry container. A morning specimen is preferred. Vaginal contamination in females will give rise to confusing results. Hence, collection of midstream clean cat sample is very important. If samples cannot be tested within 2 hours of collection, refrigerate the specimen immediately and allow it to return to room temperature before testing. The sample can be stored at 2 to 8 degree for 24 hours. Grossly contaminated samples should be rejected. Equipment: clean, dry glass slides, cover slips, test tubes, microscope, centrifuge. Procedure: follow standard precautions while handling urine samples. Label the test tube with the patient ID to which the sample is to be transferred. Mix the sample well before testing. Transfer 10 to 15 ml of sample to a test tube and centrifuge at a speed of 1500 rotation per minute for 10 minutes. After centrifugation, concentrated sediment is collected at the bottom with a clear supernatant. Pour off the supernatant till a volume of 0.2 ml is left inside the tube. The sediment is resuspended in the remaining urine by flicking the bottom of the tube. A drop of resuspended sediment is poured onto a glass slide and a cover slip is placed on it. The sediment is first examined under low power to identify crystals, cast, squamous cells, and other large objects. Then examination is carried out at a high power to identify cells and bacteria. Results and interpretation. The various types of cells and casts are usually described as the number of each type found per average high power field. The presence of crystalline and amorphous material is indicated as 1 plus, 2 plus, 3 plus, or 4 plus. The presence of bacteria yeast is also reported as 1 plus, 2, 4 plus. Any other microscopic findings such as spermatozoa, fat bodies, parasites like trichomonas and schistosoma, tumor cells, etc. are noted under the column Others. Red blood cells or hematuria. Appearance: red blood cells in urine may be seen as intact, normal shaped, or small yellow discs darker at the edge of the size 8 microns, crenated with spiky edges and reduced diameter of 5 to 6 micron, usually in concentrated urine. Swollen or as thin hollow circles with increased diameter of 9 to 10 micron and resembling yeast cells. Dysmorphic RBCs or poorly shaped RBCs in urine suggest renal origin rather than the lower urinary tract. Clinical implication: red blood cells may be found with glomerular damage, kidney trauma, urinary tract stones, upper and lower urinary tract infection, tumors along urinary tract, or acute tubular necrosis. Interference: factors that can result in falsely high number of red blood cells would be in menstrual bleeding, following traumatic catheterization, or due to some drugs like aspirin or anticoagulant therapy. White blood cells or leukocytes or pus cells. Normal range being 0 to 2 white blood cells per high power field. Appearance: usually the white blood cells are seen in urine are granulocytes. These may be seen as intact or as clear granular disc 10 to 15 micron in size, degenerated or distorted in shape, or as clumps of numerous degenerated cells. The presence of many leukocytes, especially in clumps, indicates a urinary tract infection. Clinical implication: increased number of leukocytes in urine are seen in cases of urinary tract infection, renal diseases, bladder tumor, epithelial cells. There are three main types of epithelial cells which can be shed in urine: the renal tubular epithelial cells, which are usually larger than granulocyte and contain a large round or oval nucleus and normally appear in the urine in small numbers. Transitional epithelial cells from the large drainage structures, that is, the renal pelvis, ureter, or bladder, have more regular cell border, larger nuclei, and smaller overall size than squamous epithelial cells. And then the squamous epithelial cells from the skin surface or from outer urethra can appear in urine. They represent possible contamination of the specimen with skin bacteria. Clinical implication: presence of epithelial cells in large number, mostly renal type, may be seen in acute tubular damage or acute glomerulonephritis. The presence of large number of epithelial cells with large number of leukocytes and mucus threads indicate urinary tract infection. Casts formed by precipitation of proteins and aggregation of cells within the renal tubules. Most of them dissociate in alkaline urine. Casts are usually cylindrical in shape and long when examined under the 40x objective. These may be hyaline cast, which are transparent and slightly shiny casts with rounded or tapered ends. They may be found in healthy persons and hold no diagnostic significance. Granular casts are short casts filled with the large granules, pale yellow in color with rounded ends. Fine granular casts have smaller granules that do not fill the cast and can be confused with hyaline cast. Pus casts or WBC casts are completely filled with leukocytes and are found in patients suffering from kidney infection. Fatty casts are shiny yellow casts with indented and distinct edges and rounded ends, found in patients with severe renal disorder. RBC casts. RBC cells may stick together and form red blood cell casts. Such casts are indicative of glomerulonephritis with leakage of RBCs from glomeruli or severe tubular damage. Waxy casts are shorter and broader than the hyaline cast. They appear homogeneous and waxy with yellowish tinge. Waxy casts may be found in chronic renal disease or tubular inflammation or degeneration. Bacteria. Bacteria are common in urine specimen because of the abundant normal microbial flora of the vagina in the female and urethral meatus in both sexes, and because of their ability to rapidly multiply in urine standing at room temperature. Therefore, microbial organisms found in all but the most scrupulously collected urine should be interpreted with condition of the patient. Yeast. Yeast cells may be contaminants or represent a yeast infection. They are often difficult to distinguish from red cells but are distinguished by their tendency to form buds. Crystals. Crystals are formed by precipitation of urinary salts when alteration is in various factors like pH, temperature, and concentration affect their solubility. The precipitates can be true crystals or amorphous material. Common crystals seen include calcium oxalate, triple phosphate, and amorphous phosphates. Rarely, crystals of cysteine, leucine, tyrosine, which are found in special renal conditions, can be seen. Quality control. Internal quality control. The controls should be run daily. Internal quality control can be performed using control strips or tablets, or liquid urine control of two levels, normal and abnormal. In our demonstration, we will use the quality control strips. Each positive control strip is a firm plastic strip to which are affixed 7 separate analyte areas. These contain one or more natural or synthetic ingredient that, when dissolved out of the analyte areas in a measured quantity of distilled or deionized water, produce a positive controlled solution. The negative control strip contains 6 separate analyte areas. The ingredients dissolve out of the analyte areas when the strip is immersed in distilled water to produce a negative control solution. These strips can be used to detect the performance of the reagent strips and also to confirm the user's ability to perform and interpret the test correctly. Adhere to manufacturer's instruction while storing the control strips. Procedure for performing quality control with quality control strips, as recommended by the manufacturer. Take 12 ml of distilled water or deionized water in a test tube. Remove a control strip from the bottle and cap the bottle tightly. Place the strip into the tube and cap it tightly. Gently invert the tube back and forth for 2 minutes. Allow the tube to stand for 30 minutes at room temperature. Invert one more time, then discard the control strip according to the laboratory protocol. Now treat this solution as a control sample for testing the reagent strips being used in the laboratory. Follow the same procedure for reagent strips as described earlier. Follow manufacturer's instruction as reagents in the solution may have variable stability. Record reactions from reagent strip on the quality control log. In case of positive findings, strip results should be counter-checked by manual tests. The table shown on the screen shows the values of the positive and negative control strips. These values will vary as per the manufacturer and are provided in the control insert. Alternatively, the liquid control can be used directly for checking the urine strips being used in the laboratory. The liquid control is poured over each analyte pad using a dispenser tip so as to soak them completely. The color change is then compared with the chart and recorded. The values assigned to the lot number is provided in the control insert by the manufacturer. Proficiency testing. Split sample testing should be done once in 3 months by 2 technicians as per NABL 112. Inter-lab comparisons should be done as per feasibility.